Today on the Transplant Help, we're going to be talking about CAV, aka also known as coronary allograft vasculopathy. Now, that may not be exactly how you say it, but I promise you, this is one of those things you really need to understand. You need to get a grasp of, so go ahead and stay tuned. Hit the subscribe button and click the bell notification to become part of the Transplant Helper community. Hey folks, welcome to the Transplant Helper again today. My name is Jim Merle. Now, today we're going to be talking about another one of those subjects that I think we really need to be made aware of, albeit I understand many of you, to begin with, will have absolutely no idea what I'm talking about, and that's actually a good thing because what I'm talking about today can be very, very scary. So that's exactly why we're having to speak on this topic, and that is to better prepare us in case, heaven forbid, we ever have to face such in the future. We'll have an understanding and maybe be able to really face this a little bit better, okay? And that is, today we're talking about CAV, and that is coronary allograft vasculopathy. Again, I'm not sure that's how you say it. You know as well as I do, I'm absolutely not a medical doctor, so I'm going to make some mistake in the pronunciation, but I hope today's information will help you out nonetheless. Now, the reason we're talking about it, this CAV, is because there are going to be about 32% of us that are diagnosed with this within the first 5 years post-heart transplant. And increasing in that, there are going to be about 53% of us that will be diagnosed with this within the first 10 years post-transplant. Now, we want to live long lives. We certainly want to get those 10, 20, some even 30-year marks. I'm so happy for those folks. But we have to understand there are certain things we face just because we are heart transplant recipients. And CAV, unfortunately, is just one of those. Now, with that said, we're going to be talking about this in from several different perspectives, I should say, several different points of view. And the very first one we're going to talk about today is what I would call the danger of CAV. What is the danger of CAV? Well, in a nutshell, I know this will be blunt, kind of maybe lacking tact or whatever, but bluntly speaking, the biggest danger of CAV is that it is also known as another one of those silent killers, okay? It's one of those things that many times you're going to be asymptomatic. That is, you're not going to have any symptoms, so you're not going to be able to determine yourself, okay, I think I'm dealing with CAV or anything else for that matter, because you may be asymptomatic, at least in the very beginning of this. And it's not until you're a little bit more advanced, in the advanced stages of such, that you may become symptomatic. So that is why it is so important that, number one, we have a good transplant team who's willing to follow us and willing to do the proper testing. And number two, that we always submit ourselves to being a part of that. You know, don't miss appointments. Don't try to reschedule appointments too often. Be there when they ask you to, and make sure that you're being taken great care of, okay? And I've had rants on the program before because I get very aggravated when I see teams who don't care for their patients. And this is one of the reasons, because CAV, as well as other things, are very high risk for us post-transplant, and it can be a silent killer. So being that it's asymptomatic, you really need to have a team watching over you carefully to catch this and have early detection. That's the key to really coming through this, is early detection. Now, number two, not only are we talking about the danger specifically, but I also want to talk about the detection itself. You know, what are some of the things like symptoms, if we get to a stage of this, that we're going to notice? Well, the very first symptom may be something like simple angina or chest pains. You may have chest pains. They won't necessarily be heart attacks, but you may start having chest pains. And that's because the blood is being restricted, the flow is being cut down in these different vessels, veins, and arteries in and around the heart, and that causes pain, or could cause pain within itself. Now, if you're a female, let me say, just like with a heart attack, oftentimes that within itself can be silent. You may not have pain, or the pain may be in a totally different place of the body than it may be, say, for a male. So again, that's another risk of this that we have to bring up, but you may experience chest pains. Number two, it may just be general fatigue. It may be edema or swelling. It may be shortness of breath, palpitations, you know, all that type of stuff, which if you're a heart transplant patient, you probably already understand, sounds just like regular heart failure, right? It probably sounds a little bit like what you experienced pre-transplant. So I think because of that, you and I may be more aware and in tune with our bodies and catch it a little bit earlier. But again, keep in mind that may not happen for a while. The risk of this, as a matter of fact, is there at 1 year, but symptomatically oftentimes doesn't develop to that 5 or even that 10-year mark like we've already mentioned. So, really keeping in tune and knowing how to early detect this for yourself is one of those ways. Now, one of the ways the doctors are going to do this, and this blows my mind, I never really understood what they were doing, but when you go into the clinic, sometimes the doctor has you to lay back, maybe at like a 45-degree angle. You lay back on the table, and then they reach in, tell you to turn your head to the left, and they start kind of just pressing right here around the jugular. What they're doing right there, they're not only looking for fluid like we have assumed, they're looking for higher pressures, which can be indicators. Higher pressures than the jugular can be an indicator that you might have CAV. Okay, so that's what they're looking for, and that's a part of the detection of this early on. So, cooperate with those tests, not that you would refuse, but make sure that those tests are always done by your transplant physicians when you're in clinic. Now, with that said, let me back up into something I needed to mention already, but CAV is not the same as CAD, or coronary artery disease. Now, they present themselves the same, they're often treated much the same and such, but CAV is strictly what happens to a transplant patient. CAD, with a D like dog, that can occur with anyone, and that's a narrowing of the arteries just like this is, but that's caused by plaque. This is not plaque. This is just the artery, kind of, in the way I see it, just says, hey, let's just narrow, let's just squeeze. And so the artery itself, or the vessels, I should say, could be smaller ones, they just constrict on their own. And again, we don't have a lot of control of that. So we talk about the danger, we talk about the detection. What about the determining factors or the risk factors that may help you to kind of pre-diagnose if this is a possibility? Now, the doctors already know this, and this is information they don't do a very good job in most cases of sharing with us. So let me share them with you. Number one, if your donor was over 50 years old, just so happened my donor, Dickie, was 50. If your donor is over 50 years old, you're at high risk. If your donor had high blood pressure, if your donor was a male, you are at higher risk than if you got a female heart. And I've done a whole program back, I don't know, a year and a half ago on is it better to receive a heart from a male or a female? In this case, probably a female, but you can watch that to understand it better. And then the last one here, and I certainly don't want to cause any panic, but I have to be honest, if your donor had CMV, that's CM as in Mickey Mouse, I don't know, CMV, if your donor had CMV, you're at higher risk, okay? And a lot of our donors did. As a matter of fact, over 80-something% of Americans today have CMV. So there's a very high chance your donor could have had that. Don't take that as a means of panic, but just understand that you may be at higher risk for this. So that's just some of the determining factors that play into whether or not you may eventually have this CAV, okay, whether or not you have to deal with this or not. Now, with that said, what about the actual diagnosis? How are they going to diagnose and say for a fact Jim Burrell or whoever it is has CAV? Well, the first thing they're going to do, they're going to notice that jugular. Like I mentioned, that's definitely not an invasive test, but that can at least give them an idea. Second to that, and you're having this done routinely anyway, they're going to do lab work, okay? They're going to look at certain different things. Oftentimes you'll hear them talk about the BNP panel. That panel within itself has a lot of detectors in it that may indicate this being a possibility for you, okay? They're also going to notice what we oftentimes call, in layman's terms, the cardiac enzymes. That's not exactly what this is, but they're going to notice the cardiac troponins. Again, I'm not a medical doctor, I apologize, but they're going to notice the cardiac troponins, and that can be a definite indicator that something's going on. That's the same things that are looked at if they suspect someone's had a heart attack. They can measure those blood levels and then turn around and say, okay, it's highly likely this person has had some sort of attack. In this case, narrowing of those vessels. So CAV could be a part of that. So that's the first of this, the lab work. Second, they're going to do something like an angiogram, and you likely have those done on a regular basis. Anyway, for me, I have that done every year, annually. They're going to do an angiogram. That's going to be extremely vital in diagnosing this, because they're going to put you in kind of a cath lab situation, maybe through your wrist, your neck, through your groin, and they're going to inject some dye, and that dye is going to help them to actually visually see these vessels, veins, arteries, whatever, narrowing. narrowing, and they're going to be able to say, okay, now I see the narrowing. Why does that occur? And that's when they may do what we refer to, again in layman's terms, is they may stick a camera in us. Not literally, but they may go in and do actually an echocardiogram, but by actually inserting it in the vein. You may have had one done on the table with all the greasy Vaseline stuff earlier, but they're going to actually go in through the cath process, and they're going to visually look around through the inside. And you see this on television sometimes where they can go around and it's like they see everything, and they can determine, is this narrowing? Is it caused by this condition, or is it plaque like anyone can have? And they'll make a determination in that. Now, from that point on, they may do that intravenous ultrasound. They may do echoes. They may do stress tests. They may do pulmonary tests. All these just follow-ups to try to determine whether or not you have this, because I'm not going to go into detail about it, but there are some things that visually present themselves in the same way, or with the same symptoms, and even with the same perspective or views, even during these more invasive tests. So they don't want to make a mistake on this. But nonetheless, supposing that you do have it, we have to add to this, and I'm just going to put another D word with this, how are they going to doctor that? Okay, we've noticed the dangers, we've noticed the detection, we've noticed the determinations or determining factors, we've noticed now the diagnosis. How are they going to doctor this? Well, the answer is, there's a lot of different ways to do it. Now, ultimately, this could actually end in you having to have a second or whatever number transplant. You could have to have a new graft, a new transplant done. That could be the end result. Hopefully, prayerfully, they caught it earlier than that, and so there are other options. Things like medications are actually options, and many of those medications, by the way, are actually things you may already be on. Basically, I can't say this one. Everolimus? Anybody on everolimus? Comment below if you are. I think that's how you say it. Everolimus, Surimus, you've heard of that. Tacrolimus, also known as Prograf. Anything with an emus on the end, if that makes any sense, anything with emus on the end can actually help to prevent and or treat this. Now, the problem comes in that many of us are already on those emuses, and so, they may already have a max dose out on us or something like that, and it may be the case that we've developed this in spite of being on those medications. And that's really what kind of, again, makes this a little scary, because they've already given us a lot of the drugs they use to treat it. But in addition to that, they can use typical statins, just like they would with someone with CAD or coronary artery disease. They can use typical statins. There are many of them that I won't try to list out because I don't pronounce these medicines very well, as you can see. But things like myfortic, mycophenolate, those are actually options if you're not already on those, again, and they may swap one between the other. Microfil, I think, is another kind of a variant of that, one on the side of the other. They may try some of these medicines or elevate the medication itself, raise the levels back up. I know you look forward to coming down on your medicine. They may raise those back up because they may want to slow the progression of this. And that's certainly what you want them to do, to slow or stop the progression of this so that you don't have to face possibly the end result. Now, I know this video has kind of been an overview, but it's probably an overview of something you may not have ever had a view of at all. And so maybe it has helped today. Again, we've talked about the dangers here. It could be sudden death. I'm being honest. We're talking about the way they detect it. That is, what are your symptoms? How do you feel this? And it's basically like heart failure symptoms. We talked about the determination. Why are you at risk? What are the risk factors? We talked about the diagnosis. What do they specifically do? And we talked about the doctoring. How do they doctor you, or how do they, help you along the way with this? Now, let me say at the very end again, this is absolutely treatable. It can have some very poor outcomes, but it's absolutely treatable. So please, please, please don't panic. Don't give up hope. There are options out there. Just work closely with your team. Do what they need you to do. Cooperate, things you would already be doing. But definitely, you need to get on top of this. You need to know about it early. Early detection, just like with other diseases, is the key to making this something you can definitely live your life with and live it to its fullest. Thank you so much for joining me today. Until next time, each of you, stay stronger, friends.